Welcome to the deep dive. Our mission today is to give you a shortcut to being fundamentally well-informed by synthesizing your key sources.
Right.
We're taking a really high-level view of human development. First, looking at the ideal roadmap laid out by some foundational psychological frameworks.
And then we're going to immediately pivot and see what happens when that roadmap is. Well, when it's fundamentally altered by a critical condition affecting early life. Cerebral palsy.
Yeah, and this deep dive is really all about that synthesis, isn't it?
It is. We're bridging the abstract, Erikson's psychosocial theory and Piaget's cognitive theory with the very concrete physiological challenges of cerebral palsy, or CP.
And for any professional listening, understanding both sides of that coin, the expected milestones and the nature of the disruption, that's just essential.
It's everything for effective intervention.
It's humbling, actually. You look at these beautifully laid out step-by-step pathways for typical development, and then you have to confront the immense effort and adaptation required when a condition like CP just throws that whole trajectory off course.
Absolutely.
So we're going to spend some time exploring not just the definitions, but the really profound connections between them.
Sounds good.
So let's begin with the psychosocial roadmap, the one from Erikson. When you first study this theory, the immediate insight is that human development is ongoing.
Yeah, it's not just for kids.
Exactly. It's a lifelong sequence of achievements.
And what's crucial there is the focus on the psychosocial aspect. Erikson structured life as this series of, you could call them levels of achievement.
Okay.
He recognized that people are constantly facing new developmental tasks, and those tasks are based on their social world. It goes way beyond adolescence.
And the engine driving all of this development is, well, it's conflict, right?
Precisely. Every single stage is framed around a developmental task that has to be successfully accomplished. Erikson saw these as a crisis.
A crisis sounds negative.
Well, not necessarily. More like a critical turning point.
Yeah.
The health and the robustness of your personality really depends on how successfully you navigate that crisis.
Let's make that a bit more tangible. So if we focus on early life, the very first stage is trust versus mistrust.
Right.
If a baby's needs are met consistently, they navigate that conflict, they develop trust. But if that resolution is partial or unsuccessful,
then the consequence is a lasting feeling of inadequacy.
and this is where the synthesis really begins to kick in.
It is. If a child is facing significant medical challenges, repeated hospitalizations or painful therapeutic interventions right from the start, that initial psychosocial crisis of trust versus mistrust becomes so much more complicated. Does the framework you're using give you a way to mitigate those early lasting feelings of inadequacy?
That's the real challenge, isn't it? Understanding the ideal while you're managing the reality. This framework isn't just theory. It's a tool for assessing risk factors for someone's future emotional health.
Exactly.
Okay, so now let's pivot from that social and emotional roadmap to the intellectual blueprint. Piaget's cognitive theory. This shifts our deep dive into how knowledge is acquired, how it's organized, and ultimately how it's used in the brain.
So Piaget outlined that cognition develops in 4 distinct phases. The rate can vary, of course, but individuals move through them in a necessary preset order.
And for our discussion today, we're really honing in on the first one, right? The sensoromotor phase.
Yes, absolutely. That foundational stage. It spans from birth to roughly 2 years old. This is the period where infants learn by coordinating what they sense with what they do. Sensory experiences with motor activity.
Okay, let's unpack the mechanism there. So within any of Piaget's phases, there are these 3 concepts that define how we process information.
Assimilation, accommodation, and adaptation.
Right, and these aren't just definitions to memorize. They are the actual gears of learning.
They absolutely are. So assimilation it's the easier cognitive function. It's when you use a pre-existing schema. A current framework of knowledge you already have, like knowing how to pick up a toy.
Well, understand a new situation. You just fit the new data into the mental blueprint you already have.
Perfect example. So if a child knows how to grasp a rattle, they assimilate that same motor action when they're given a spoon.
What? What happens when that spoon is too heavy? Or, say, they can't exert the required strength because of some physical challenge.
And that
Uh,
requires the heavier lifting. Accommodation.
okay.
Accommodation means the current schema has to be altered, or sometimes a completely new one has to be created to handle the unique demands of the new information. You have to fundamentally restructure the mental blueprint.
That sounds like a constant, kind of tiring process.
It is, and that constant striving is what leads us to the third concept, adaptation. Adaptation is the big overarching process. It's the lifelong effort to adjust to new information and new demands from your environment.
Through that careful, continuous balance of assimilation and accommodation.
You got it. And if we connect this to the bigger picture for you, this balance is precisely what therapists try to manipulate to promote cognitive and motor growth.
That immediately gives the theory such practical relevance. It's humbling to realize how much of development is simply adapting the box, you know?
It really is.
We've spent time establishing the theoretical frameworks that map out ideal development. Now, we use those frameworks to understand the profound contrast posed by cerebral palsy.
Yeah.
This moves us entirely into the physical and neurological realm, where the disruption to those expected motor milestones is immediate and it's very clear.
So CP is defined as a group of chronic conditions that affect body movement, coordination, and posture. It's vital to recognize the etiology here.
What's the root cause?
It results from a non-progressive abnormality of the immature brain.
Non-progressive. That term is key.
It's so key. The damage isn't getting worse over time, but the long-term impact is huge because the insult happens when the brain is still building its foundational connections.
So this insult to the developing brain, it can happen in the late stages of pregnancy, during birth, or sometimes within the first couple of years after birth.
Exactly.
Right.
And because the damage affects the motor centers in the brain, the impact ranges across a huge spectrum. It can be mild mobility issues that you'd barely notice, all the way to really profound physical challenges.
And it might or might not include an intellectual disability.
That's right. While CP always affects motor function, that's not always the case for intellect. Pathophysiology-wise, whether it's congenital or acquired, it just comes down to damaged or abnormally developed immature brain matter that regulates muscle control.
So that raises an important question that our source really emphasizes. Since movement control looks so different from person to person, why are the categories spastic, dyskinetic, ataxic, and mixed-war, why are they so crucial to understand?
Because the categorization directly dictates the management plan. You can't just say it's CP.
It's not one size fits all.
Not at all. For example, spastic CP, that's the most common type. It involves increased muscle tone, which leads to stiffness and exaggerated reflexes. But on the other hand, you have dyskinetic CP, which involves uncontrolled, fluctuating movements. You can't treat stiffness the same way you treat involuntary, rapid movements. Understanding these distinctions is foundational.
Let's review the clinical process then. If we suspect a child is showing developmental delays, how is CP formally diagnosed and what does management look like?
Well, the diagnosis relies on a confluence of information. You're looking at a detailed patient history, thorough clinical findings, motor and neurological tests.
And often brain imaging, I assume.
Often, yes. But what really stands out to me is the timing. CP is usually diagnosed between 12 and 24 months.
Right in the middle of that sensor-motor phase we were just talking about.
Exactly. The child is supposed to be mastering object permanence and building their most fundamental motor schemas.
So the diagnosis hits precisely when the child's brain is intensely focused on coordinating movement and sensory input. That makes the disruption highly impactful to their cognitive development too, not just physical.
Absolutely.
Yeah.
So once that diagnosis is secured, the goal shifts entirely to lifelong management and support. It's all aimed at maximizing mobility and independence.
And we know treatment is multi-pronged. It can incorporate surgery, medications, and therapy. Let's expand on those last two.
Sure. So medications fall into several critical classifications. You'll need drugs designed to manage symptoms like spasticity, so muscle relaxants, or medications to control co-occurring issues like seizures.
The goal is symptom relief, to make movement and learning easier.
Right. And then you have the therapeutic interventions, PT, OT, and ST.
What's the specific goal of each of those?
Okay, so physical therapy, PT, focuses on gross motor skills, walking, sitting, mobility, and strengthening key muscle groups.
The big movements.
The big movements. Then occupational therapy, OT, is geared toward adaptive daily living skills. That's often fine motor control, like eating, dressing, writing.
Finding ways for the child to successfully engage with their environment.
Exactly. And speech therapy, ST, is critical. It focuses not just on verbal communication, but also on crucial functions like swallowing and feeding.
It all becomes intensely practical. Align these therapies with the child's current developmental stage. It really underscores why those broader learning resources mentioned in our sources, the guides for specific age groups like infants and toddlers or adolescents, are so necessary.
The interventions have to constantly evolve with the child's development, always pushing the boundary of what their schemas can achieve.
So we've completed this journey. We've moved from the abstract, the beautiful frameworks of Erikson and Piaget,
Which map out the theoretical potential of
to the
development.
very tangible physiological reality of conditions like cerebral palsy that profoundly challenge that potential.
The true value of this knowledge isn't just knowing the definitions of assimilation or accommodation or the 4 types of CP.
Right. It's in appreciating that synthesis. It's recognizing the intense intellectual and physical effort that's required for a child with CP to establish new motor and social milestones, constantly working outside the typical expectations.
Which leads us to a final provocative thought for you to explore.
Okay?
Consider the timing again. A child is diagnosed with CP between 12 and 24 months. Their fundamental schema for walking, for grasping, for manipulating the world is defined by this condition from the start. So how might the early intervention therapies, PT, OT, ST, how might they fundamentally bypass the easy assimilation stage and aggressively force a wholesale recreation of their schema? That's accommodation on a massive scale just to adjust to their body's demands.
Wow.
It's not just learning, it's a forced structural redesign of their entire cognitive blueprint for movement. And that necessity for deep accommodation, that is perhaps the most powerful driving force in their early life development.
A profound point on which to reflect. Thank you for joining us on this deep dive. We hope this knowledge serves you well.
Until next time.
Keep adapting.